Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your guide through this dermatology series, designed for primary care practice and PANCE prep. Today we'll be diving into melasma, a common and challenging pigment disorder. We'll cover its causes, clinical presentation, and how to approach its management in primary care. So let's get started. Starting off with some basic pathophysiology, melasma is a chronic condition characterized by hyperpigmentation due to hyperfunctional melanocytes depositing excessive melanin in the epidermis and dermis. It's strongly linked to hormonal influences such as pregnancy and oral contraceptive use, as well as ultraviolet exposure. Other contributors include genetic predisposition, certain medications like photosensitizing drugs and anticonvulsants, and certain cosmetics. Who does melasma affect? Melasma is particularly common in women of reproductive age and in individuals with lighter skin types. Men can also develop melasma, but it's less common. As far as clinical presentation, patients present with symmetric, hyperpigmented macules and patches with irregular borders. These lesions typically appear on sun-exposed areas such as the face, with the cheeks, forehead, nose, upper lip, and chin being most commonly affected. Melasma is largely a clinical diagnosis based on its characteristic appearance and distribution. However, dermoscopy and Wood's lamp examination can be helpful if needed. Now, let's talk about the management. The management of melasma is often challenging, with incomplete responses in many cases and frequent relapses. The cornerstone of treatment is strict photoprotection, including sun avoidance, sun protective clothing, and daily use of broad-spectrum sunscreens. Colored formulations of sunscreens containing iron oxide provide additional protection from visible light and can be used for cosmetic camouflage, both during active and maintenance treatment. For pharmacological treatment of mild melasma, first-line treatment is with hydroquinone 4% cream, which inhibits melanin production. And for patients with moderate to severe melasma, the fluocinolone hydroquinone tretinoin triple combination cream is recommended. Regarding prevention, it's important to educate patients on sun avoidance and how consistent sunscreen use is critical for preventing relapses. Here are a few clinical pearls to keep in mind. Number 1. Hormonal influences are a major trigger. Always ask about pregnancy or contraceptive use. Number 2. Strict photoprotection is one of the most important steps in managing melasma. And number 3. Educating patients on the chronic and relapsing nature of melasma helps set realistic expectations. Now let's practice some questions. Question 1. A 35-year-old woman presents with a 3-month history of a rash to her face. She is 5 months postpartum and reports regular sun exposure without sunscreen use. Examination reveals symmetric, irregularly bordered, hyperpigmented patches on the cheeks, upper lip, and forehead. Which of the following is the first-line treatment for this patient? Is it A, chemical peel, B, hydroquinone cream, C, oral corticosteroids, or D, laser therapy? I'll give you a couple of seconds. If you chose B, hydroquinone cream, you are correct. Hydroquinone is the first-line treatment for melasma, inhibiting melanin synthesis. Sun protection is also essential to prevent progression and relapses. Question 2. A 34-year-old woman presents with a gradual onset of a facial rash over the past 6 months. She recently switched to a new oral contraceptive and spends time outdoors, jogging daily. She denies any pruritus or systemic symptoms. Exam reveals symmetric, hyperpigmented patches with irregular borders on the cheeks, upper lip, and forehead. No erythema or scaling are noted. Which of the following is the most significant contributing factor to her condition? Is it A, UV exposure, B. Iron deficiency, C. High glycemic index diet, or D. Fungal overgrowth. If you chose A. UV exposure, you are correct. Ultraviolet exposure is a major risk factor for melasma. Other contributing factors include hormonal influences such as pregnancy or oral contraceptives and genetic predisposition. Iron deficiency and diet are not major contributors, and fungal overgrowth is not a pertinent factor for melasma. Great job! Thank you for joining me on this episode of the Pro PA podcast. Melasma can be a tricky condition to manage, but armed with the right knowledge, you can make a significant impact on your patient's quality of life. Don't forget to tune in for our next episode. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.